tribal echo. We are recording right away because we have our elder at the end of, we're going to have an outro instead of an intro from our elder today. I'm going to hand it over to Lindsay and Tina. We have an exciting new format today, so I'm just going to let them take it from here.
Thanks, Lindsay. Sorry, that was my bad. That was completely my bad. Yeah, so we're going to do something a little bit different today. We're going to do a panel discussion, kind of a year in review. We just looked back at the echoes that we did this year, particularly the ones done by NACC staff. And we kind of gathered some questions and are going to facilitate just a little panel discussion today. So kind of onward with our regular slides. So I think most people on here know, but just a little bit about NACC, Native American Community Clinic. We were established in 2003. We're a federally qualified health center, otherwise known as an FQHC, and we're located in the heart of South Minneapolis on Franklin Avenue. We provide primary care, Suboxone, and other medications for opioid use disorder, infectious disease intervention and treatment, social service support, dental, behavioral health, intensive outpatient, elder care and traditional healing services, and other health promotion and maintenance programs, as well as harm reduction services. Moving on.
So some session guidelines, no protected health information, please. We ask that you mute yourself if you're not speaking. Welcome to eat your lunch during the session, of course. And then if you could let us know who you are in the chat, name, title, organization, email would be great. And we do invite you to use the chat if you have any questions or comments. And feel free to kind of think of questions that you have so that we can talk at the end. Let's see, announcements. So this will be our last session for the year. We'll reconvene January 4th and have Tina and James return to kick off the season with Harm Reduction 101. This is just a list of a few of the echoes that we recommend. Other than ours, we have Indian Country Echo that has a large catalog of topics. We also have Stratus Health, who we partner with, and Hennepin Healthcare. Continuing education, we do offer CE credits. We just ask that you fill out the survey that I'll email to everyone after the session. So again, if you could make sure to put your email address in the chat, that would be great. And then case presentations, we definitely encourage if you have difficult cases or success stories to share, it makes for a great discussion and learning. And if you have one, you can always let me know in the chat, or my email address is on the screen there too. So I'm going to actually stop sharing and pass it over to Tina so we can get the discussion started.
Awesome, thank you. Just another plug that if you are joining as an audience member, please put your name and email address in the chat. Since our attendance taking practice has changed a little bit. As we go through these questions, we're just going to leave 5 minutes for each respondent. And just to let everyone know, once we hit the 4-minute mark for each person, we will just pop in and introduce and give a little warning that there's 1 minute left. Any other housekeeping stuff? I think that's about it. So we're going to start out with a question for our executive officer, Dr. Antony Stately, who gave a couple presentations, I think, this year. One about sort of HIV and like harm reduction, and then another specifically about like historical trauma. So Dr. Stately, how has NACC demonstrated incorporation of trauma-informed care and practices into the clinic since its opening? And how have things improved or not improved? And where do we need to go next?
Wow, that's a big question to answer in 6 minutes, because that's all I get is 6 minutes.
5.
5. Ooh, okay, all right, well, okay, well, let me just jump right in. I think I want to thank you, everyone for joining us. I'm really very privileged and honored to be asked to be a guest in our look back over 2022. I'm very, very proud of the ECHO and my ECHO team and the work we do, our harm reduction team and our substance abuse providers, and I think it is doing really amazing work, and also our traditional healing and spiritual care providers. How NACC has changed over the last year, or am I going all the way back to the beginning? Might not have the time to go back to the beginning. So I think that we've made significant strides and leaps and bounds over the last year or two in terms of sort of the work that we do with respect to harm reduction, and also with respect to the integration of that philosophy and that approach to our work across the enterprise. That's been a real intentional focus of our work over the last couple of years, not sort of like just doing harm reduction as a thing that we do on the side, like a side dish, kind of like, I know Minnesotans love their side dishes and their casseroles and whatnot, but, we try to take a much more sort of like holistic approach to sort of kind of bake it into sort of like what I guess, for lack of a better word, I would call it like the secret sauce, right? It's kind of like, making it like be part of the philosophical and the approach that we take across the enterprise to ensure that we are, I call it showing up as a good relative. I think about, in fact, actually on my drive to work this morning, I was talking to somebody, a relative who was struggling with substance use, and they were asking me about resources in the clinic. So I was talking to them about this and this, and then, I kind of like, well, I didn't actually jokingly say this to them. I actually pointedly said this to them. I was like, yes, you can come to NACC, and yes, you can ask for these things. And yes, we have all these things that we can do. What I want you to do when you show up, because I do have some relatives that do this, they come and they sort of like come in a more sort of like demanding way. And I said, like, I as the executive officer, but also as your relative, I want you to understand, like, we try to show up and be a good relative in that space and place. We expect you to sort of kind of join us and reciprocity. And so, what I talk about from that perspective is like being a good relative is, is like listening, being curious, being responsive, recognizing in a humble way that we don't have all of the answers, that the patient or the person we're engaging with has some of those answers. They need some support sometimes, they need advocacy, they need all these things in order to sort of kind of activate or potentiate better outcomes. And that's a big part of what our job is. It's not necessarily to sort of like give them the solutions and or tell them or pontificate about what they're supposed to do to sort of kind of make their life better. But a good relative also doesn't do things like, I think there's a lot of confusion also in our community and across healthcare broadly, and also across substance abuse treatment broadly, about what harm reduction is. And the reason I like to sort of like use the philosophical sort of like indigenous value of being a good relative and showing up in that space is that our job, since from creator's perspective, is that we're brought here to this earth to sort of walk a path with everybody that comes and joins our path, to support and to be as helpful as we can. It doesn't mean that we are, doormats and allow people to walk all over us and do whatever they want. We are allowed to sort of like put boundaries in place and also just sort of like say what we can do and what we can't do. And to show up in that space and place and be as best of a relative as we can. supportive where we need to be, advocate where we can, help navigate and remove barriers so that people can benefit from their experience, but also the things that they might not know exist that are out there that can help them. We've tried really, really hard over the last several years to sort of make that a really foundational value and perspective and philosophical approach for the clinic. And I think that we've done some good work in that area. Are we perfect in that? I don't think that we're perfect. I think that we, I don't know, I'm pretty proud of my team. So I think we're close to perfect, but we all need a little bit of work. But that's also the human condition. Like, the human condition is to recognize that we are not perfect. We are perfectly imperfect as Creator made us, and we're always on a learning path. And I think we try our best to sort of, approach the situations that present themselves to us every day and try our best to sort of learn from them and do a better job every time we sort of kind of circle around. Life is a circle, and you're going to experience similar conditions as patients and providers and helpers and relatives. And every time you cycle around and meet that situation again, you might be able to draw on wisdom and knowledge and experience, but you also might have to be curious.
Just a heads up, Dr. Stately, 1 more minute.
Okay. So is that, what was the other part of the question?
Oh, the other part of the question is, where do we need to go next in terms of trauma-informed care? We just have 1 more minute.
I think as a clinic, as an organization, I think we have really well-trained providers and people that understand the nature of trauma, understand it from like a historical lens as it relates specifically to Indigenous communities and the impact that that's had on us. I think we do a good job of sort of understanding contemporaneous trauma or contemporary trauma as it shows up in the lives of our relatives when they come and seek services with us, or as we meet them out. And a lot of you do outreach work, and you're seeing those people in the community. And so we have those things really well. I think one of the things we've been having a lot of discussion with ourselves internally about sort of like the work that we need to do individually and collectively as an organization about sort of turning that lens inward and looking at our own experiences of vicarious and secondary trauma, and how do we do a better job of taking care of each other and taking care of ourselves so that we can show up and be the best relative that we can in all of our interactions. And I think that's a space and place we have to do some work still.
Awesome, thank you. So the next question is for Dr. Rabie, who has given some really good talks about harm reduction in general, harm reduction incorporated into a primary care practice, and also working with our pregnant patients around MOUD. So Dr. Rabie, what has your journey been with working with pregnant women in your addiction medicine practice?
Thank you.
You're on mute.
Sorry.
Sorry, we're all in the same room. We're just playing our usual Zoom games over here, so apologize. Yeah, so I think that generally speaking, that that there's been I've experienced sort of like a progression of like my thoughts and practice around opioid use disorder in general, and then pregnant women in particular. And I think that like when I first started working within the community, I pretty much had a lot of thoughts and practices that reflected the medical community in general. And also like ideas around CPS. So, like the ideas that, like what a woman is using when they're pregnant, we should report them, that's the best thing for them and their fetus and their baby is to, get, involve services get external services involved in their care and all of those things. Also, I think that, at the beginning, when I first started working at NACC, I sort of, I had a lot of the same viewpoints that a lot of other providers do, stigmatizing chemical use, stigmatizing patients who were especially pregnant and using, and sort of like, how, asking myself, like, how could you use and be pregnant? I don't not really having a good understanding, and honestly not having competency in caring for people who use drugs, caring for women or people who are pregnant and using drugs, and really not coming at it from the right place. So when I first took care of pregnant women, we did pregnant people using drugs. We did urine toxicology routinely because it felt like that was information I needed to have, and for a woman who was using drugs and pregnant, in order to better care for their pregnancy. And then, of course, we go into that whole reporting and everything. And what we found in our practice is that women wouldn't show up for care, or they would show up once. They would have a negative UTOX. We would try and have the conversation with them, come back to us no matter what, but we'd try to have that conversation with them, and then we wouldn't see them again until they were like 36, 37, 38 weeks pregnant, because they were trying to do it on their own. They were sort of feeling like they needed to get themselves together. They didn't want to have child protection involved in their pregnancy and their lives. They really wanted to go home with their children or their babies after their babies were born, and we were not giving them the support and help they needed to have that happen, and we were re-traumatizing them in this context. So I would say that we were in a very different place than where I am at now. And I think that, it's been kind of like a series of realizations over the course of my practice which has led me to where I am now. And I'm sure there will be more realizations to come. We've always have space to room and grow. So I think one of the first realizations that seems really obvious to me is that when a woman came in and was using and pregnant, was to just say, congratulations on your pregnancy. I'm so happy for you. And I had more than one person say to me, I have never had anybody ever say congratulations to me when I came into a medical office because of the chemical use and the other pieces. There's just like that automatic stigma attached to being pregnant and using that makes it that so they can't even be happy for being pregnant. Like somehow there's just so much shame coming at them, right? I think the other thing that we did that after conversations with people in the community, like Lisa Shefty, is like we really examined why we were doing the urine toxicology screening, what's the purpose of it, and so we did stop doing the urine toxicology screening routinely. And what I've learned, like as far as that goes, it's like if a person is not engaging regularly in care, or they're not showing up, a lot of times you can sort of surmise that there's something going on, like chemical dependency. And so to have a really frank conversation with every person that comes in about chemical dependency and about we're here for you regardless, and it's being easier with the mandated reporting laws changing. We support you no matter what. What are your goals? We want you to get there. Our goal is to have baby come home with you. To be able to have all those conversations and allow them to come forward with the information that they're using when and if they're ready for it, but make sure that every woman or person hears that we are there for it, we have the resources available, and we want to help them regardless. And then when they are ready to disclose, they will disclose to us. And my experience has been, with the changing of the mandated reported law and a different perspective on our part, I am now taking care of pregnant women who are actively using, not ready to stop using quite yet, but are still coming in for visits.
Just want to say 1 minute left.
Thank you, Tina.
Yep.
So I think that has been a huge piece. And again, I think that a lot of this is about, becoming competent in the care that I'm providing, and I think for providers in general, to being open to learning from the community that you serve, and to take a position that is not a directive position, but more of a collaborative position in the care that we provide to pregnant women, and just to be aware of that double stigma that comes when you're pregnant, and that you're inviting child protection into your life, you're inviting all sorts of other people into your life just by virtue of the fact that you're pregnant, and it's not always a choice. And to just be aware that women have an internalized stigma. They don't, they would rather not be using and be pregnant, and yet there they are, and this pathway out is not always as simple as you might think, and we're here to help them.
Thanks, Dr. Rabie. So moving on to Michelle, now who is our MAT nurse manager. When we were reviewing, one of the questions that came up for us, we just noticed that people use both terms, MAT and MOUD. So with your expertise, we were kind of hoping if you could clarify, are they different? What's the difference? Which one should we be using? So that's the first part of our question. And the second part of our question is just knowing how unique the program is here at NACC. Just wanted you to speak to how these programs can be better tailored to meet the needs of more people.
Oh my gosh. So I think most of us are pretty well in the habit of using MAT or MAT. And really what that means is medication assisted treatment. And that's kind of the concept of, using medication to support or augment, supplement treatment for chemical dependency, chemical use disorders. And the MOUD has kind of come along to really highlight the medication itself. While MAT can mean, Vivitrol, naltrexone, really any medications for alcohol or other substances, MOUD is really about opiates. So medications for opioid use disorder is specifically referencing, methadone, Suboxone, Sublocade, those medications. And part of the reason that SAMHSA came out with that, or really started using that instead of MAT, was that the medications are shown to do good on their own. Even without the treatment component, these medications are shown to improve outcomes and really help people manage their opioid use disorder. So, MAT is a pretty broad category, right? There's medications for all kinds of substance use disorders that fall under that. MOUD would be one of the more specific MAT categories. There also comes in kind of some other terminology. Some people hear MAT or MAT, and that is only an OTP, or an opioid treatment program. And that's a methadone clinic, a typical daily dosing program. And, as we've all seen, MAT, MOUD is really changing quite quickly, and we're having to come up with new terms to really talk about what we're doing. But a lot of us still have kind of the old school terms. So MAT used to mean a dosing program. And then when Suboxone came about and was available by retail prescriptions, the term, really, the definition had to change. And so I think what we see with MOUD is just getting more specific, right? And really highlights kind of what we're doing. We're really trying to get medications for opioid use disorder, highlight the fact that they work really well on their own, and are not just used to supplement some other services. So I hope that helps. As far as, how can programs be more tailored? I think the way to be more tailored to the folks that we serve is to actually remove the barriers. So removing barriers and allowing for easier access to things then allows folks to access the services that are going to be helpful for them. Allowing for, walk-in type services, I don't know, I think a lot of people see this quite often where clinics will do things like, oh, if you've had 3 no-shows, you're not allowed to be seen here anymore. Things like that. That really eliminates a whole category of patients who could be served. So if we eliminate some of those barriers, we're actually expanding the number of people we can serve and work with. And as folks engage in programming or move along in their recovery path, what they need is going to change. And so it doesn't really matter that we have removed some of those barriers because they've, kind of moved past the need for less barriers, if that makes sense. Does that help?
Yeah, that's great. Thank you. Okay, moving on to, we're gonna direct our question towards James Schmidt and China Pfeiffer, a couple of our leaders in harm reduction here at the clinic. And James is one of our harm reduction health educators, and China does a lot of work around harm reduction and as a peer recovery specialist. So currently, what does the syringe service program or harm reduction program look like at NACC? And then the second part of that question will be, what are the benefits and challenges of having those programs in a clinical setting?
Hello, I'll start it off with just giving an overview of our syringe exchange programs and harm reduction work at our level at NACC. We continue to do HIV testing and HCV testing events every Monday. That's kind of changed. We have to modify it as the clinic's been remodeling right now, but that's been continuing. It's been very successful, and one of the things that we were able to start doing with that is also being able to provide actual syringe exchange through the clinic again, which is something that we were not able to do since I've been here, since like 2018, within like an actual syringe exchange setting. So that's exciting. We've been able to expand the team. One of our advocates, Paige, patient advocates, Paige, has became a DIS worker, and now we were able to hire Javon from coming from Chicago, Illinois, to be our non-medical case manager. So we have a larger group, which allows different things that we weren't able to do, or it just gives us, like me and China or whoever's been going out and doing outreach, a lot more support. So that's been pretty awesome. Lindsay is another addition to that, which has been great. Let's see, Thursdays, we continue to do street outreach like Dr. Stately spoke about. We do go into the community, both every other Wednesday at the Vivo Tiny Village. And then also Thursdays, we try to hit the different encampments and so forth. We've been able to expand the type of the type of supplies that we're handing out, like more tents, more camping supplies. As camps continue to get displaced, that becomes like a much greater need every year, it seems. But also we're able to distribute smoking supply, safer use of smoking supplies on a greater level. And that's been really helpful in a harm reduction.
No, I don't.
Manner in which it helps reach other stuff like endocarditis and so forth. And we've currently began, like a thing that I'm really like is that we've currently began to increase our attention on street cleanup, syringe cleanup in the neighborhood, which we do know feedback has always been an issue. So we've been out there. We go out Wednesdays, and then now we're going to increase that to Fridays, where we're hitting the whole East Village neighborhood and just focusing on picking up syringes and the materials that we hand out in safe use kits. And just overall, it's been really great to, I think we just really create like a wonderful environment for folks that are people who are using drugs to be able to come to the clinic and feel okay and treated with dignity and respect by not just our team, but the clinic overall. And with that, I'll pass it on to China.
Hi, I'm China. I'm a peer recovery specialist with NACC. And I'm going to talk about the benefits and challenges of having a syringe service program in a clinical setting. So some of the benefits are like ease of being able to link people to care, like if they are needing other services that NACC provides, medical or dental or MHE, whatnot. It's a lot easier to just, hey, let's walk over here and see if we can, make an appointment, or, even if a walk-in's available. And then at NACC, as opposed to during meeting with participants, during an outreach, a street outreach setting, we have kind of more of a opportunity to be able to sit down and speak with a participant, one-on-one, with privacy and outside of away from the elements, and during street outreach or pop-ups and whatnot, it can get kind of chaotic, and a lot of people are needing stuff, and it's just more conducive, at NACC to have a space to do that. Some of the challenges, some participants may not feel comfortable coming in, to a clinic or a medical kind of setting due to past experiences, traumatic experiences in that kind of setting, or experiencing stigma. Another challenge is the ability to provide low barrier access to our participants while still not disrupting the flow of the clinic, or overwhelming other staff, or the front desk staff and patients as well. And that kind of brings me into goals for the future. Right now, our HIV testing events on Monday. Right now, people are able to come in through a separate entrance, in the back, but we don't have an area for them to kind of sit and be warm. And it would be nice to be able to have a space available like that. People a separate entrance. People can avoid going through the lobby area and access syringe services and HIV testing and linkage to care.
I will also mention too, every Tuesday we have a harm reduction group that China hosts over at the MOUD, and it's pretty great, and it does allow us an opportunity to have more conversations with folks, which we always are thinking about how we wish. Sometimes in encampments it can get really busy and really chaotic, and it's hard to have one-on-one dialogue, and that gives us kind of the testing events more availability for space to have educational talks and just overall conversations. So.
And then also, over at MOUD, now that people kind of know that I'm here, we're able to have people walk in, the front staff here, know where the supplies are, and are always willing to get people their supplies and offer them coffee, place to sit and warm up for a little while, because it's just less traffic in and out over here. So that's really nice. Yeah.
This is the highest risk population, probably not only in the city, but in the country equally. And so for them to feel comfortable and welcome to come to the clinic is such an essential part, I believe, what kind of Dr. Stately spoke about as the whole moral of our clinic, which is wonderful. And I'm personally grateful and thankful to be able to be a part of it.
Thank you, guys.
Thank you, James and Tina. So we'll move on to Mike. Hey, Mo. Oh, sorry.
Hi.
Hey, so you're our new patient navigator, and I know you've done the harm reduction as traditional presentation a couple of times that everyone loves. Just a question for you, how do you practice some of the 7 grandfather teachings that you talk about in that presentation, like in everyday life and difficult situations? Could you talk a little bit about that?
Yeah, sure. So I'm not always adept at following them every single time that I have interactions with people. Sometimes I feel comfortable with people and I might not use wisdom, or I might not really think about that. And so it's a part of what I do, or else like in my past, working with individuals where maybe they were very loud with me and others in our workspace, and so then they got kicked out, and I'm like, wait a minute, like I've had to think about it, and I'll be like, that's not harm reduction. And so I've talked about it with like my peers in harm reduction, and as well as like with creator and in my own being, because I didn't want that person to not get services. And so what I did was that I just put the word out, that I was looking for him and that I needed to talk. And so what happened was he came in within a half hour, and I let him know that his voice levels, like I have my own traumas, and so like high voices where they're loud and angry, I can't hear them. All I hear is wah 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 wah. And then now, but as so I was able to tell him that I can listen to you when your voice is at a regular space, and that if we can acknowledge that I need that and that you can provide it, like I don't mind you coming back. And I said that also, like the way that you have treated the other people within this organization, that like you have to realize that we're here for you, but we're not your emotional battering ram or whatever, and so that we also like understand that you come from a place where you're dealing with a lot, but we don't we also need respect. I want to respect you and let you be in this space and get the services that you need without without being banned or being told that you have to leave again. I said I'd rather not that happen, because I'd rather you get the services. And this person and I, we made an agreement with each other, and he started coming back and getting the services that he needed that was provided by us. And it's really important to face things, even like if you make mistakes, and to just understand that sometimes we're human too, just like Dr. Stately said earlier, and that sometimes we do make mistakes, but we also can take responsibility for our own actions and rectify the situation with the person that we need to, or with the situation that we need to. And it's a really hard place to be that responsible, but at the same time, I really think that it's important for our clients to see that as well, and to be really like open and honest about those things that are flaws and within ourselves, because we're important as the services that we offer to others. And to recognize that within ourselves, that we have to continue to work on who we are. And so I've had to do that many times, and even recently, and it was so hard. And but I face things because I have to, because I love this work and I want to continue, and I don't want to be I try to be as transparent as possible and face things regardless of the consequences, because I know that it's better to be following these teachings that I really uphold, because they're important to me. It's important to me to treat everybody good in a good way. I don't know. That's just the way that it is for me.
Oh, thank you, Mo. All right, so we'll move on to Nikki, who is our infectious disease nurse. Nikki, you did a past presentation on safer drug use, which I know a lot of people are interested in that topic. So a couple of questions for you on that. How do we at NACC create a welcoming and non-judgmental environment to prevent trauma from communal experiences for people who are using? And what tools do we provide to make people feel empowered for helping community members feel safe?
Yeah, well, I think a lot of people have already said a lot of the things that I was thinking about saying. So just everything that everyone already said. I think recognizing that the program participants are often really they are themselves harm reduction providers and educators, in their own communities and lives and families, and that often like the information that we have that we're kind of presenting on harm reduction is coming from people who use drugs, and so they're actually the experts. So I think that we work here on trying not to kind of create this automatic assumption of like that the service provider is superior or has more knowledge, and to rather treat the people that we're serving as experts, kind of like Dr. Stately said. People often have their own answers. We're kind of offering support, tools, resources, the stuff that we're privileged enough to have access to. And then I think also that sort of like radical acceptance of substance use as something that just exists, not necessarily always something negative, and certainly not something that ever makes somebody less worthy of a service. Like James was talking about, just treating people with dignity and respect, positive regard, talking about drug use in neutral ways rather than ways that have sort of negative judgment woven through them. And then Michelle was talking about this too, trying to avoid firing people from programs for things that aren't actually harming somebody, that aren't, so if it's not violence, and if it's not, like a fear that someone's putting themselves at risk by like combining multiple substances, something like that, then there's often not really a need to fire someone. It can mean a lot when somebody knows that they can keep coming back to you regardless. And I guess just trying to consider whether the thing that someone's doing, maybe missing a lot of appointments repeatedly, is actually sort of due to, traumas they've experienced or drug laws or something like that, the very things we're trying to fight against, rather than something like innate within them that makes them less worthy of the service. And then in terms of empowerment, I think, having people delivering services who use drugs or who have used drugs in the past, getting those folks on staff or in as volunteers, trying to take folks seriously, reimburse them for their work. I know James has a program now at NACC where he is doing, he's hosting volunteers from the community, and that's incentivized time. And so, yeah. I guess that's what I've got, and then everything that everyone else said too. So thanks.
So last question, I will direct to those who had the opportunity to attend the harm reduction conference in Puerto Rico this year. So I guess, are there things that you learned that you want to share with the group? Any upcoming ideas for harm reduction that you'd like to see implemented at NACC in the future, and just kind of future plans for 2023 and beyond?
So many things.
So many things.
One of the big things I took away quite a few really important things. One was using Suboxone or MOUD as a way to just increase safety of ongoing use. Meaning, not everybody wants Suboxone because they want to stop using. They may use it for some protection from overdose, or they don't want to necessarily feel the effects of what might be in their meth, things like that. And really kind of thinking outside the box as to how can we use the tools we already have to keep more people safe. One of the things that was quite shocking to me is just how many parts of the country or parts of the world don't have fentanyl in their entire drug supply. And I thought, my gosh, like we're experiencing that right now. And if we could have a more concerted, larger worldwide, international effort to really help each other, because we see it's coming, right? I mean, if it's happening here, it's going to happen somewhere else. And so kind of using places like that conference to get together more often and talk about what's happening and kind of work together to keep people safe. So that was one thing I took.
I think you also took the inspiration, or I guess more energy, to create naloxone vending machines, nasal naloxone vending machines, which was, I think that's an exciting thing.
Yeah, and I think that adds, like, that kind of speaks to the removing barriers, right? So now let's make it so folks don't even need to come into the clinic. They don't even need to access a service. They don't even need to necessarily speak to a person.
They don't
right?
need permission.
Right, they don't need anything. They can just access a vending machine and, starting with Narcan, eventually adding in other things that kind of fall under that safer use or harm reduction umbrella. Making it literally accessible to anybody who can physically get to the space.
To be clear, that's a wish list. We wish we had that.
It's a wish list. Yeah.
Not yet.
Not yet. It's one of the many moving pieces that we've got going. One of the things that I have like a bunch of notes that I feel like are all loose ends that are just going to start to synthesize maybe as time continues forward. But one of the things that someone said on like the closing panel, she was talking about like, she's a leader in the movement and a leader in the organizations that she works for. And she said this thing that stuck with me, which is good leadership involves succession planning, which to me is also to say that like, if you are holding power, you are not hoarding it, you are sharing it. And that not just as like a leader, like supervising people, but like a service provider in the community. And that has sort of inspired me to think more about the way that we like engage our participants. And some of the other talks that I went to, I was really interested in like data and like research, and some folks who do research in the field of, drug use. They don't give out gift cards. They literally pay their participants, and they teach them, this is your W-2. We're going to give you a W-2. We're going to help you with your taxes. And it's actual real payment. And they teach the skills also in a way that is, I guess, made me think that it was more empowering than like incentives. So yeah, I don't know, China, we have less than a minute, but I want to make sure you have, I'm going to put 1 more minute on here.
I think the biggest thing for me was, feeling up until that point, I had started feeling kind of, powerless and just like helpless as far as like the situation, and so many people, young, dying, and just kind of feeling like things aren't going to change. And just to hear what other people are doing and the progress that they're making. And it was very well attended. I think it was like more than the first 2 conferences combined. And so it was just like kind of rejuvenating and, made me come back and feel like, yeah, we can do this.
And Mo, I know you went also, so I want to make sure you have a minute.
A minute. Well, my minute is about the safe consumption room. So I had an opportunity to volunteer in that room, and it was like, really there was 3 rooms, and one was for testing drugs, one was for the snacks and like sitting around, and the other one is the entrance room. So we had to make sure that the supplies that we had was always hidden and stuff like that. But what I really found was like how the people that were in there helped each other to make sure that they were like dosing correctly, and like had their little tips that they shared with one another on their use within that building, because there was no fentanyl there, but there was fentanyl available to the people that came to the room. So there's no fentanyl on the island, but in that room there was.
Yeah.
And so like even doing that, it was just to help the people who came to the conference to be able to be there that are still using. And I really felt really glad to be a part of that space. And I hope that in the future, that when that comes to fruition here, that we're all a part of it.
Me too. Thanks, Mo.
Mhm.
Thank you. So I think we have a little bit of time if we want to open it up for any discussion, if anyone has any questions or comments for any of the panel members.
Was
I have
it
a
too much
question.
information? Yes, go ahead, Alana.
Sorry. My question would be to any of you, I guess. What would be the biggest education that you can give to really anybody to help reduce stigma around substance use disorders?
Oh, where to start? One of the things I tend to think about is, just as an organization, when folks are coming here for services, whether it's, hey, I want to join a treatment program because I want to stop using, or hey, I need, STI testing, they're reaching out for those services for a reason, right? And like they're seeking to take care of themselves, and supporting them while they do that, right? So I hear this idea that like, oh, if they're using drugs, they don't care about themselves. Well, they do, and they're here to get something from us, right? And whether, I mean, that should be enough, right? The fact that they're here. That's it.
And I think I'd also say that there's a lot of research. So even if you're looking for proof, there's a lot of really, standardized research that shows that stigma hurts and harm reduction helps. Sort of right these universal wrongs that we can all agree with, So
I want to throw a comment in here. Sue Purchase said, who gets to define it as a disorder? Perhaps substance use management might be a better term, which thank you for that. I think sometimes I think about like language as being sort of like the foundational step and starting to think about how to remove stigma, and thinking about, I think sometimes we tend to like rely on making language simpler, when making it simpler actually causes more stigma. Like saying people who use drugs takes longer to say than drug addicts. But saying people who use drugs is much more nuanced and takes the judgment out of it.
I think of when you guys are saying this, I think of I know lots of folks who are on Suboxone, buprenorphine, naloxone on some in some form, but continue to use other substances. And I don't know, it doesn't seem very disordered to me, and right, I love that. Like, who decides that that's a disorder? I mean, So they're, the ICD-10 code that's in their chart, is gonna be, meth use disorder. But they're doing fine, and where they're at in their recovery is where they want to be in their recovery, or whatever you want to call it. So yeah, I think that's an important thing to talk about.
I think recognizing and helping people to understand that, so substance use, that people drill down and they say, oh, it's a chemical, it's, alcohol, or it's meth, or it's this or that, but substance and use is a really broad term. It can include, I've seen people addicted to sugar who are not the healthiest individuals, and they behave very crazy when they don't have it.
Yep.
Members of my own family do that. And so so part of it is helping people to understand, this is a term we use, and it's a broad category, and it includes a lot of things. And then trying to make the analogy, or helping people to understand the parallels between that and other kinds of health challenges or concerns that are common, right? I always, depending on the person I'm talking to, and I have people in my own community who I've had really, really challenging and dicey conversations around harm reduction and substance use and addiction with, where I'm if you had somebody who is diabetic, who quote unquote relapses on 12 packs of donuts and goes into a full-on what would happen to them? I don't know. They DKA perhaps or something, and they end up in the hospital and they have all these other things. I said, we don't really go we don't really get really judgmental with them about it and talk about how they need to be committed, or talk about how they're irresponsible and maybe we should consider taking their children away, and all these other kinds of things that we do around other substances alcohol, drugs, and other kinds of things. But the disordered part of it is that the not the very good management of sort of your use, right? And so part of it is helping people to sort of unpack that term and apply it to other parts of their lived experience, so they can kind of say, oh, I'm not the only person that has challenges with this specific thing. This is a health condition that I'm not managing well, right? And maybe I might benefit from having some support around managing it better if I choose to do that. And so I think trying to strip it from all of its, what do you call it? Provincial and colonial sort of heat or burden is probably helpful for people. So.
And I would just really
Thank
mention
you.
real quick too, that a lot of the ideologies towards drug use is based on about 100 years or so of racist ideologies. And we need to always remember that some of those narratives have sprouted from some pretty toxic ways of thinking. And they continue kind of like a pebble in a pond, ripple effect as time goes by. And fortunately, these days, we're starting to take a look at that. And I think that that's just a really huge key part of how we do stigmatize folks who are using drugs.
Yep. That's a really good way of sort of acknowledging well, who gets to decide that it's a disorder? Usually it's somebody in structures that are deeply racist and other sort of oppressive and colonial structures that get to say this is inappropriate behavior, or this is an inappropriate outcomes. There's lots of very wealthy people that use drugs that never have any significant societal challenges from their use of their substances. And I know some of those people, they're more disordered than the common average man or woman.
So
And of the people here, by the way, I should say that.
Thanks, Dr. Stately. So just to respect everyone's time, it's 1:02. I think that we are ready to close now. I could definitely stay on here and keep talking about all of this.
I know.
I feel like that was just a warm up.
I love the best of. I think we should do it more than just once a year. We should do it.
Yeah.
Brilliant idea.
So too.
Tina.
Yeah.
Thank you.
So thank you everyone for coming. Thank you to the people who joined the panel, and thank you for being willing to do like a rapid fire. I know 5 minutes is not a lot of time. Again, if you haven't already, put in the chat just your email, name, organization if it's relevant, and we will make sure that we'll send out the evaluation survey to you. And also if you need CEUs, we can get you that, we can get you those as well. So
Marissa threw in here, she'd like to hear what everyone's wish list is for the future. If you have time, what's your harm reduction wish list?
I'm happy. I will
next time too.
I will stay on, respond to this.
I will, can I go first? Because I got a 1 o'clock that I'm late for.
I do have appointments, so goodbye,
Yeah.
everyone.
Bye, James.
So
Thank
really
you.
quickly, I want to do two things. One is I want to just tell you all to have a really wonderful holiday season with whomever and how many ever you love, and that you have a really blessed solstice and celebration with your families, and a good start to the new year, because we won't see you again until then. And also to just thank you all for being a part of this work. This is really deeply meaningful and important work in our community. And NACC is honored and privileged to have all of you in partnership in this work. So thank you so much. The folks at Stratus, thank you so much for all of your support and partnership. I also wanted to just say, like, don't forget to take care of yourselves in that time as well. But also my wish list for harm reduction is that sometime in the very near future, every single person on the planet needs to have some naloxone on their person. And we need to be training everybody from like the moment they can walk and talk to the to use naloxone, because it's so easy to use that even a 2-year-old can do it. Maybe even a really, really smart 1-year-old, capable 1-year-old could do it. But we will save more lives if we can just, get over our provincialness around some of this and educate and provide more resources to people from cradle to grave. So
I think that's one of the things we don't talk about enough is the stigma that comes with just carrying Narcan.
Yeah.
That's huge.
Anyway, that's my wish list for the new year. So we'll see. Hey, we have a unintended guest here, Nurse David, who all of you know.
Hi, Dave.
Honored to be here. I hope this echo continues, and I'm very grateful for the topics you guys choose. I think it's amazing. I think it's meeting a need that and crosses out of Minnesota borders into other areas too, to I think highlight the work that you're doing, because it's, I think, recreating the model that's needed now for the folks that I think are finding it harder and harder to connect to healthcare and finding an in so they can get the services they need. I think you're highlighting a new recipe for that. So thank you.
Thanks for joining us.
Thank you.
You, Dave. Nurse Dave.
My big wish list is that grant funds could become less restrictive and prescriptive, and that we could even, I know that this is like really far in the future, but if we could just start giving people money, like just give people cash. I think that it would cut out a lot of, first of all, time and effort on the part of organizations, and just would like spread the wealth and spread the power, and yeah, just pay people cash.
Well, this isn't an endorsement politically, but there was a presidential, what do you call him? Running for the president in the last election, which I can't remember his name, Andrew, but that was what he wanted to do.
Mm,
Pay everybody in the country
yeah.
a certain amount of money just for existing.
Universal income. Yeah.
Universal income.
I think, actually, so there's a pilot program happening in Minnesota for that. The applications for it closed. But it's just going to be a pilot, and I don't know exactly when it starts, but I don't know. We have like that excess $1 billion in the state, so maybe
It's very
they'll decide
interesting
to-
concept. And I think as we move further into the, sorry, everyone's probably ready to go. I got a meeting too, but
No, but I just want to keep talking.
it's
We don't have
interesting
you on very
concept.
often. It's exciting.
And as we move further into the future in this, revolution of social revolution where people are not going to want to even work in the same environments that we are in now. It's a huge revolution and it's happening before our eyes and it's got to change. Things have got to change. But anyway, I have a nurse meeting. I got to go and it was really interesting. I loved it.
Thanks
Thank
for
you.
coming, Marissa.
Thank you.
And thank you all. We will see you in the new year.
Oh, wow.
And I think it's going to be me and James talking about, I don't know, just kind of like going back to basics with harm reduction. So
Thanks, everybody.
thank you all.